Hey everyone, we're going to begin now. I want to welcome you to the fourth workshop and the final workshop in the Good Clinical Practice series. It is entitled When is Informed Consent Truly Informed? I will introduce our speaker in a moment. I just wanted to tell you that if you're still interested in micro-credential, go ahead and email me. I'll put that information in the chat. Certificates of completion, you will receive a couple weeks after the workshop is finished. It usually takes some time to get signatures, and if you attended all four workshops, as long as you were there a certain amount of time, you should receive the certificate of completion. I also want to tell you that we have two more workshops for this particular semester. On November 6th, we have a leadership workshop given by Marcia King. It's all on coaching and how coaching can lead to leadership. And then on November 13th, we have a translational teamwork one that we'll be advertising really soon. And I want to thank Sevie Kandefer for taking over for this particular workshop. Looking forward to it, especially with all the engagement factors. And she is a clinical research associate in the clinical research office at UB. And I will turn it over to her. Thank you.
Okay, well, thank you. And I just want to say, usually I think Dr. Christian Marks gives this presentation and he does a fabulous job with it. So I hope I can do half the job that he does. So I guess we will just get started. So the learning objectives are to recognize information in specific sections of the research protocol as corresponding to information being conveyed in the consent process, and to review a guide for designing a consent process to improve informed consent in the future. So as we know, informed consent is a process and it can be broken down into three parts: the conveying of information, the understanding of the information, and affirmation of free choice. And that is followed by documentation, both in the signing of the informed consent form and in your documentation of that process in your source documents. So we're just going to go over the who, what, where, when, and how of consenting. So what to convey? Now, there is a correspondence between the UB-IRB protocol template, the HRP 503, and the UB-IRB consent form template, which is the HRP 502. So if I say 503, I mean the protocol document. And if I say 502, I mean the consent document. So what needs to be conveyed? There are the required elements, which we're not going to talk about here. If you don't know what those are, you can look those up. But in addition to the required elements, you also want to include anything that would be relevant to a reasonable person. So the informed consent forms are now formatted in a way that there's a concise and focused presentation of that key information that is most likely to assist somebody in deciding whether or not they want to participate. And so you really want that organized and presented in a way that is easy to understand. So starting with the title. So in CLIC, there are fields for both a long title and a short title. So the title listed in CLIC should match the title on your research, your informed consent form and your research protocol. So, sometimes we start like cutting and pasting and we kind of forget to check the title, but it's really important that that title matches. And it can be the long title, it can be the short title, it can be both titles, but your research titles should match across all your documents to what is in CLIC. Why am I being invited to take part in a research study? This comes right out of Section 8 of the protocol document, where you describe your inclusion and exclusion criteria. And this doesn't need to be a cut and paste situation either. You want to highlight just a couple inclusion criteria, maybe an exclusion criteria, just to explain why you're asking one person to participate and not another. So you're saying things like you're being invited to take part in a research study because you're a healthy adult who likes to exercise, or you're being invited to take part in a research study because you've been diagnosed with type 2 diabetes. Why is this research being done? So this is going to come out of Section 4, the background section of the protocol, maybe 5, study design, maybe Section 6 if you have an intervention or an investigational agent. And this also may not be a cut and paste situation. Your protocol might be written with more scientific or technical language, and you really want to use simple lay language when you talk about the purpose of your research. The recommended reading level is a 6th to 8th grade reading level for a consent form. So when you're describing the purpose of your research, you really want to think about, like that's a middle school age reading level. That's like an 11 to 14-year-old. So are you describing the purpose of your research in a way that is easy to understand? And I always really like to see that sentence that says the purpose of this research is, to see if the study drug is safe and effective, or the purpose of the research is to collect, attitude or opinions on a certain topic. I like when you see that clear statement and it's written in a simple and easy to understand way. So here's the QR code. I don't know if everybody can try to scan that. It should take you to simple A and B choice. You shouldn't have to log in. But if you can see that, which language would you use in a consent form? Would you say the purpose of this study is to learn about brain activity during deep brain stimulation or DBS surgery? Or would you say the purpose of this study is to examine neuronal firing rate and pattern during DBS surgery? Which language would you go with? And if you have trouble with the QR code, let me know. Okay, do we think that's enough time? A few more seconds. Okay, let's see. Does it work? Yeah, okay. A, I agree. Now, there's not necessarily a wrong answer here, right? But A, the purpose of the study is to learn about brain activity during deep brain stimulation, DBS surgery. If you say what brain activity is to a middle schooler as opposed to neuronal firing rate and pattern, brain activity is certainly easier to understand. And DBS is spelled out in A, deep brain stimulation. Every time you use an acronym in a consent form, it should be spelled out that first time you use it. Even if you know what it means and most people know what it means, it really should be spelled out that first time. Okay, so how long will the research last? This comes out of section 13, specifically 13.2 of the 503, where you're asked to describe the duration of an individual subject's participation in the study, include the length of study visits and overall study follow-up time. So you're really describing how much time a person will spend in the study. So maybe we expect you'll be in this research study for 2 hours. Maybe we expect you'll be in this research study for up to 5 years. You'll have monthly visits the first year, annual visits after that. Visits will last between 1 hour and 5 hours. You were really just describing how much time an individual will spend in your study. And what will I need to do? And is there any way being in this study could be bad for me? So we're still talking about that concise and focused presentation of information in the beginning of the consent form. And I really recommend that you actually fill out the long part of the consent form on these questions, and then really summarize that and kind of hit the highlights for this beginning focus presentation. So you do like the long portion first, and then come back and answer these. Will being in this study help me in any way? So 24.1 of the protocol asks you to describe the potential benefits for individual subjects. Compensation cannot be a benefit. So this is usually the section if you're working on a medical study, you say your symptoms may improve, they may worsen, they may stay the same. If there is no direct benefit to your study, you just simply say that there is no direct benefit to participating. You can go on to say, mankind will benefit, but you don't have to. You can simply say that there is no direct benefit to participating. That is completely acceptable language. What happens if I do not want to be in this research? So there is no comparable section in the protocol for this. I think it's because it's so study specific. So if you're working on a clinical trial, you're usually listing alternative treatments, medications, surgeries, procedures. If there really is if you really don't want to be in the research, you can simply say you may choose not to enroll in this study. That again is acceptable language to use. Your alternative is not to participate. And this is also a nice section to add. If you have a population of students that you're recruiting, you may want to say your grades won't be affected whether or not you decide to participate. If you are recruiting patients, this is a nice spot to say your treatment won't be affected whether or not you decide to participate. How many people will be studied? This comes from section 7 of the 503, where you indicate the total number of subjects enrolled locally, and maybe 31.1 if you have a multi-site research study. So I just want to point out that when they say enrolled, it means consented. So sometimes if you're working on a clinical trial, you might consent somebody, you screen them, and then they screen fail, so you don't technically enroll them, like per the sponsor. But here we're asking for the number of people who are consented. And maybe you're consenting 50 to get data on 25. You would still say we expect about 50 people to be in this research study. You can be more specific and say to get complete data on 25, but you don't have to. But you do want to say that the higher number of the subjects you expect to consent. Now, what happens if I say, yes, I want to be in this research? So this is going to come from section 12, where you discuss your procedures, maybe 14, where you talk about your setting, 6, if you have an intervention or an investigational agent, the privacy section of the protocol, 18, confidentiality, which is 20, and if you're banking data or specimens for future use, maybe section 32. And it's important to remember, lay language, simple terms. You're really trying to describe what it will be like for somebody to participate. What can they expect? And if you are working on a clinical trial, you also want to make sure you're distinguishing between what is research and what is standard of care. It's really common to see consent forms where there's a long description of a procedure, and really that procedure it's going to happen whether or not somebody decides to participate. The research is really the collection of, personal health information into a separate database. So it's important to distinguish what is research and what is standard of care. Okay, so one more, at least 2 more QR codes. Number 2. So would you say, A, during visit 2, you will complete the QOL and MAS and have your vital signs measured? We will measure your muscle stiffness using a handheld device called a myotonometer. The probe or testing end of the device will be placed perpendicular to the skin surface directly above the muscle to be measured. We will maintain skin contact and slightly compress the subcutaneous tissues. A brief mechanical impulse lasting 20 microseconds will be applied. We'll record the muscle oscillations using an accelerometer. Or would you say during visit 2, you'll fill out questionnaires about your health and quality of life and have your height, weight, blood pressure, and temperature measured. We will measure your muscle stiffness using a handheld device called a myotonometer. Let's see, what do we think? Okay. Okay, so we think A. So A absolutely has a lot of detail in it. It tells everybody exactly what's going to happen. I actually like B on this one because, first of all, for A, the QL and MAS, will everybody know what that means? If you say someone, I'm going to ask you to do a QOL and MAS, probably not. If you say questionnaires about your health and your quality of life, they may know what that is. And as far as the level of detail, so you're really explaining what the level of detail is in A. Is any of that relevant to somebody deciding to participate? Do you think somebody would say, like, 20 microseconds is way too long? If you would have said 10, I'd say yes, but 20, I don't think so. Maybe not. But if you're really going for that middle, 6th to 8th grade reading level, then they may not know what 20 microseconds is, or what subcutaneous tissue is, or how you're measuring muscle oscillations using an accelerometer. I like the language in B myself. Again, no wrong answers. If I were obtaining consent, though, I would also like to have a picture of a myotonometer, or maybe have a myotonometer available so you could show the subject what would happen. We're going to have this device. We're going to hold it on your skin like this. There'll be a little bit of pressure for about this long, so people have an understanding of what is going to happen. Okay. So one more, which language would you use? Would you say you're being asked to participate in the study because you are scheduled to have a craniotomy? The decision to have a craniotomy was made by you and your doctors before you were asked to join the study. Taking part in the study is optional. If you take part in the study, you'll be asked to complete 3 questionnaires 1 week, 1 month, and 3 months after your craniotomy. Your craniotomy surgery and treatment will not change whether or not you join the study. Or would you say, you are being asked to participate in the study because you're scheduled to have a craniotomy? A craniotomy is a surgical removal of part of the bone from the skull to expose the brain. Specialized tools are used to remove the section of bone called the bone flap. The bone flap is temporarily removed, then replaced after the brain surgery has been done. You'll be asked to complete 3 questionnaires 1 week after your craniotomy, and again 1 month and 3 months after your craniotomy. Let's see. Yeah, A, I think is really clear that you're getting the craniotomy is more of like an inclusion criteria than a study procedure. So sometimes it is appropriate to describe standard of care assessments in your informed consent form. But when you go into a lot of detail in a craniotomy in your consent form, something like this, then you may start to wonder, well, is that actually the research? Like what is the research and what is standard of care? A clearly says you're getting a craniotomy, whether or not you decide to participate, that is happening. Okay, subject responsibilities. So what are my responsibilities if I take part in this research? This can come from section 12, the procedure section of the protocol, maybe 26, the economic burden to subjects, maybe your responsibilities to pay for parking. For clinical trials, I always like to say things that were a little unusual for subjects. Maybe there were certain birth control requirements. Maybe they had to abstain from taking meds at certain visits. Maybe a couple medications where you couldn't drink grapefruit juice. I like to include anything unusual. It's also really common to just say your responsibility is to, listen to your study doctor and come to your visits as described in this consent form. If this section doesn't apply to your research, this is one of the few sections that can be deleted from your consent document. If maybe you're doing a one-time survey and you don't think this really applies, you can remove this section. What happens if I say yes, but I change my mind later? So there is a lot of template language in the consent form for this. And so you can, use what is applicable, but you also want to describe your study specific information that you have entered into section 22 of the 503, where you describe the procedures for orderly termination and procedures that will be followed if a subject withdraws. So you want to use that template language, but tell people what will happen if they decide they want to leave. So usually for clinical trials, you're going to invite them back for a follow-up visit. You may be asking people to return study drug or return study supplies. Just let people know what will happen if they decide to leave the study. And is there any way being in the study could be bad for me? So there is a long list of questions about risks in the 503. 23.1 asks you to list the reasonably foreseeable risks, discomforts, hazards, or inconveniences, and that's whether they are physical, psychological, social, legal, or economic, and then describe the probability, magnitude, duration, and reversibility of the risks. 23.2 asks you to describe procedures performed to lessen the probability or magnitude of risks. 23.3 asks about which procedures have risks that are currently unforeseeable. 23.4 asks about risks to embryos or fetus. And 23.5 asks about risks to others who are not subjects. So you will almost always list confidentiality as a risk. Almost always that is at least one risk you are listing. But you want to include everything that you have put in the 503 should go in the 502, but with simple language. So you want to say high blood pressure, not hypertension, or upset stomach instead of dyspepsia. If you say someone might have an allergic reaction, you want to describe what that is. Are they looking for a rash, shortness of breath? You want to tell people what they should be looking for and what to expect. But what happens to the information collected for the research? Again, a lot of template language in the 502, but you also want to bring in your study-specific information that you've entered into section 20 about when and how data will be stored, how long it will be stored, who will have access to it, and how it's being transmitted or transported. And if you're collecting specimens, that may also come into play. But you're going to use that template language and then be specific about your study data. This is where if you're keeping paper data, you're going to say it's in a locked cabinet in a locked room. Hopefully you're not just saying that, you're doing that as well. If you're using electronic data, that it's password protected or on a secure server. You want to describe your data, say if it is coded or if it's de-identified. And everybody wants to say their data is de-identified. And that is great if it is truly de-identified. It is more likely coded. And so you're going to talk about how identifiers will be removed. The code will be placed in the document and your code sheet will be stored separately. Again, assuming you are doing that. But there's a great presentation, I think on the CTSI's YouTube page about data. I think it's like data security is how it's titled, but it talks about coded and de-identified data. And I recommend it for anybody who has a couple minutes to spare. But this is the section where you want to describe how you're keeping your data secure. Can I be removed from the research without my okay? So Section 22 talks about the withdrawal of subjects. Describe any anticipated circumstances under which subjects may withdraw. Oh, I see a question in the chat.
Yes.
Yes, I am saying that, yes, coded data is different than de-identified data. So there are worksheets. You can go online. I won't get into the details here, or we can talk about it at the end. But yes, coded data is different than de-identified data. And I think that video is probably, I don't think it's that long. I don't want to say it's only 7 minutes and maybe it's 15. But it goes into a nice description of how to handle coded and de-identified data. It is different. And so it's important in that section to describe your data accurately. And like I said, everybody wants to say their data is de-identified. Like that's like the holy grail of data keeping, but often it's just coded. If you have any date of any kind, it's not de-identified. If you have date of birth, date of service, date of admission, your data is going to be coded. And it's totally acceptable for it to be coded. You just want to describe it accurately. Okay, so being removed from the research without my okay. So this is where you are describing if you're going to remove somebody. If it's a medical study, usually if there's a threshold for symptom worsening, things like that. A lot of times people will simply say, if you don't come to your study visits or follow the instructions in the consent form, you could be removed from the study. You're just going to, again, accurately describe what you're going to do. But what else do I need to know? So who is paying for this research? What medical costs am I responsible for paying? And who will pay for my medical care participating in this research harms me? So this is going to come from the 503 section 16.3, about resources and qualifications, section 25, the compensation for research-related injury, and section 24, the economic burden to subjects. And I just want to talk about the research-related injury language, and I think that Jen is on this call, so if she wants to chime in, that's great. But for studies that are greater than minimal risk, you do need to use the research-related injury language from UB's template. And that is true even if you are using a central IRB and you are using your sponsor's informed consent form. So if that is the case, if you have a central IRB and you're using your sponsor's informed consent form, you are basically deleting all the language the sponsor has put in that section and you are pasting in UB's template language. I think that it reads, there's a statement about, notify your study doctor. There's a paragraph that says you'll receive care, but UB and its affiliates will not pay for it. There's a section that says, however, the sponsor will pay, and it lists certain conditions. And then there's a line about you're not waiving your legal rights. So the things you can change is when you say UB and its affiliates, you describe the affiliate, whether it's UB and Kaleida or UB and ECMC, that's a change you can make. And the section about however a sponsor will pay can be removed if the sponsor is not paying. And if you are not sure about that, then that means you need to reach out to whoever's working on your contract or handling that to make sure that information is accurate and it matches what is in your contract. But that language needs to be in your ICF, even if you're not using the UB template. And I like to, when I redline that sponsor form, to put in a comment that says this is UB required language, and any changes to this section will require review by UB legal. And that way the sponsor can decide if it's fine or if they want it to be escalated. And if there are changes other than removing that, however the sponsor will pay, if that's not applicable, if there are changes, then it does need to be escalated to UB legal. So make sure this section is accurate. Use UB IRB template language. Okay, and what else do I need to know? Will I get paid? What are my alternatives? What will happen to my information and samples? And what will I be told about clinically relevant research results? So this is going to come from section 27, the compensation for participation section of the 503, and then sections 12.5 and 12.6 that asks about sharing individual subject results and study results. So there's no wrong answer here for sharing results. It's your prerogative if you're sharing individual results or not, and if you're sharing study results or not. You just need to tell people what you're going to do. The HIPAA section. So if you are reviewing medical records after somebody signs consent, you do need a HIPAA section. UB really likes you to use their language again. Now, they're not as strict about the HIPAA section as they are about research-related injury language. But when you use UB's HIPAA language, it ensures that you capture all entities involved, which is usually our affiliates are going to be releasing PHI to the investigator, and then the investigator is sharing them with the sponsor, with the IRB, with Research Foundation, and you have your list. So when you use UB's template language, then you are capturing all those entities. So it's really recommended that you do. And that language should be reflected in sections 18 of the 503, where you talk about privacy, and again, that confidentiality section, which is 20. Now, if you're not looking at medical records, this is another section that you can simply delete. Okay, so that was the what to convey. On to the who, where, when, and how. So section 28, section 28, specifically 28.5 of the 503, asks you to indicate whether you'll be following SOP, Informed Consent Process for Research, is the HRP 090. And if not, or if there are any exceptions, then describe it below. And there's questions about the role of individuals who are obtaining consent, how much time is being devoted to the process, steps taken to minimize the possibility of coercion or undue influence, and steps taken to ensure that the subjects understand. So if you check that box and say, yes, we're using the SOP, you don't have to write anything here, but then you actually have to use the SOP. And if you're not using the SOP, or you're using like most of the SOP except this one part, then you have to describe the except that one part in this section. You have to explain what you're doing different from the SOP. So you can check the box, but then you actually have to follow the SOP. So who should be part of the consent process? So administratively, it's got to be a study team member who is listed in CLIC, and that yes box is checked that they are involved in the consent process. So if you have people consenting that are not listed as study team members, or that yes box is not checked, make a note right now to, at the end of this presentation, submit a modification and an RNI and CLIC, because that's the bare minimum of who could be consenting. Beyond that, who is qualified to consent? Well, it should be somebody who has sufficient knowledge about the procedures of the study, the alternatives to the study, and any potential outcomes. It should be somebody who can answer questions, is a good communicator, and can devote sufficient time to the process. It should not be somebody that would be in a position that would create undue influence to participate, or someone who is financially conflicted. And keep in mind that consent does not have to be the domain of only one of your personnel. You can have a number of people involved in the consent process. They just need to be listed in CLIC, and that yes box needs to be checked. So who else could be included? You could include family members, maybe the prospective subject's primary care physician, basically anybody that the prospective subject wants to involve. If they want to bring in their roommate, because their roommate has to bring them to study visits and they're going to be involved in like med management, that's fine, whoever the subject wants to involve. And if you are working on a study where you're using a legally authorized representative, or you have children or guardians involved, a good place to start would be HRP 013, and that can be found in the CLIC library. So considerations for who? Are the research team members who will be obtaining consent qualified to provide good information and answer questions? Are they good communicators, and can they devote sufficient time to the process? Do they speak the subject's preferred language? And is there any potential for unintended undue influence by certain team members? And is there another team member who can eliminate or mitigate that? Do you need more than one study team member involved? And should others be involved either in all cases or certain situations? Okay, when to convey. So consent doesn't have to take place overnight. It is an ongoing process. And that process starts once you identify somebody and recruitment begins, because that is when you begin conveying information. So section 11 of the protocol does ask about your recruitment methods. It asks you to describe when, where, and how potential subjects are recruited. It asks you how you'll protect their privacy, and then identify any materials that will be used. And that means social media posts, flyers, brochures, telephone scripts, websites, emails, Dear Doctor letters. Anything that is public facing needs to be IRB approved. 28.3, the protocol asks you to describe how you will ensure that subjects are provided with sufficient time to consider taking part in the study. And 28.4 asks you to describe any process of ongoing consent. And we'll talk about that later. Regarding the time period, if you are using that SOP, if you've checked the box, it says to give the subject time to discuss taking part in the research study with family members, friends, and other care providers. And I mean subject and representative, but I'm just going to say subject. And you also want to give them time to take written information home to consider before making a decision. So I would review the consent form with people, and then I would say, take this home, Google whatever you want to Google, talk to whoever you want to talk to, come back to us with questions, and then make your decision. So you want to give them enough time to decide. Now, that is not always an option. I mean, maybe you're working on emergency department studies, or you're working with, acute conditions that you don't have that luxury of time. But it's still, that time period is something that we want to be thinking about. So considerations for when. What timing should be used to allow sufficient time for potential participants to consider the information, have questions answered, and discuss it with others before making their decision? What are the circumstances for this particular study that point toward the need for ongoing consent process where you formally review consent information throughout the study? And are there any circumstances related to the participant's condition that would make comprehension of information, understanding, and/or decision-making more or less difficult? And can the timing of the consent process be altered to minimize the negatives and maximize the positives? So let's look at an example of that. Let's say you have a 56-year-old female who presents to the emergency department with chest pain and is found to have an acute myocardial infarction. She meets all inclusion criteria for a research study to evaluate a novel therapeutic modality for treatment of acute MI. The research assistant approaches the patient who is suffering from ongoing pain and anxiety. The research assistant presents the consent form, and the patient willingly signs. Now, what are some things to consider in this situation? I don't know if we want to unmute or put them in the chat. But what are some things to think about when getting consent in this type of situation? This isn't a take the consent form home, come back in a couple of weeks, and we'll enroll you. This is a you need to make a decision soon situation. What do we think?
Again, feel free to unmute, or you can type things in the chat and I can read them. Oh, we have one. She is unable to consent due to duress of the situation.
Oh, maybe.
Another
Maybe.
one is have the patient read the consent form.
Okay. Yeah, I mean, maybe this is one of the situations where you have to have a formal process for determining capacity to consent. So I was thinking more about that, yeah, the patient's in obvious distress and may not possess her usual ability to focus and discuss complex issues. Maybe she doesn't have the capacity to consent. Maybe you need somebody to make that determination. But maybe let's say she does have the capacity to consent, what can you do to mitigate this? She's stressed, she's in pain. What do we think? Well, if it were me, I would think about maybe having, if they have a family member or somebody else that's with them. Thank you. Exactly. If they have somebody else with them who knows maybe what they would normally think, who can help explain it, that might mitigate that situation. It might even make the person feel calmer and better able to make that decision. And we also want to try to avoid coercion, right? Patients should be informed of the voluntary nature of participation and should be assured that prompt and appropriate medical care will be given regardless of research participation. I mean, imagine if it was you in that ER and someone said, here, sign this, you're probably going to say, where do I sign? Okay, please just treat me. And we really want to avoid that type of undue coercion. We want to make sure it's clear that you're going to get prompt and appropriate medical care, whatever you decide. This is simply an option. Okay, so where to convey? 28.2 of the protocol asks you to describe where the consent process will take place and includes steps to maximize subject's privacy. So if you check that box that you are following the SOP, the correct answer here is a private and quiet setting, according to 3.7. If you are not conducting consent in a private and quiet setting, then you have either not checked that box or you have described how you are deviating from the SOP. So maybe you are interviewing teachers for your research and they want to be interviewed at the Tim Hortons across the street from the school. So that you would describe that, and you would also include the steps to maximize a subject's privacy. Maybe you say things like you're going to try to choose a quiet table away from crowds. But you would have to describe that process if you have checked that box, or I guess even if you haven't checked the box. The SOP also says in 5.10.1.2 that when appropriate to protect the privacy of the child, conduct this process in the absence of the parent or legal guardian. So if you are working on a study where you are obtaining assent from a child or adolescent, it is important to have a separate conversation with them away from their parent or guardian. This can be awkward. They may not want to. The parent may not like to have you do that, but it is necessary to have that private conversation and ensure that everybody is agreeable. So where will consent take place? You want to choose a location where there are no distractions if possible. It is difficult to learn in a crowd or with the TV on, or if somebody's on their phone. Sometimes getting people to put their phones down can be challenging. You also want to choose a location where the subject can be at ease. Use a conference room rather than an exam room if possible. Oh, there is a question about assent. Yes, assent language is adjusted for the child's reading ability. There are 2 assent documents, I believe, in the CLIC library. There's a 14 to 17-year-old assent, and then there is a younger assent. It must be 7 to 12, I think, but don't quote me on that. So there are 2 versions of assent depending on the child's age. Yes. So you're welcome. So yeah, when you're choosing a location, maybe a conference room is more comfortable than an exam room. If you can choose a location on the subject's turf, like I said, if you're interviewing teachers and they want to meet at Tim Hortons, that's okay. That just needs to accurately be described in your protocol. And if you can, you create an atmosphere of equality. Like consider who has the big desk or who's wearing a gown that ties in the back. Imagine you're in your doctor's office in that paper gown on the exam table and someone comes in with a 20-page document. Are you comfortable and going to give them your undivided attention? Like, probably not. We want subjects to feel at ease and like they can ask questions and say no. So of course, there are circumstances where there is no choice due to a patient's condition. But again, these are things that we want to be thinking about. So considerations for where. What locations are available for the consent process? Are they free from distraction and sufficiently private? And are there other locations available where the subject can be more at ease that also minimize the potential for undue situational influence? Okay, on to the how, using the long form. So if you are using the long form, according to the SOP 5.1.1, obtain the current IRB approved consent form. 5.1.2, verify you're using the most current IRB approved version. So you want to make sure that you are using the most current IRB approved consent form. It's listed twice for a reason. It is such an easy mistake to make to grab the wrong version. So if you are using paper copies, don't don't print a lot, only have one out at a time so you don't accidentally grab an old one. If you are printing it each time, you want one current version in that folder, not a whole list, so you don't grab the wrong one. And whosever job it is to make sure that that is up to date, it is such a super important job because it is so easy. It is such a common deviation to just grab an old version. You really want to try to make that as foolproof as possible. So the SOP also says 5.1.3, provide a copy consent to the subject. And again, I'm going to say subject instead of a subject representative. And whenever possible, provide that ahead of time. 5.1.4 says, if the subject cannot read, obtain an impartial witness to be present during the entire consent discussion to attest that the information in the consent form and any other information provided was accurately explained to and apparently understood by the subject and that consent was freely given. The witness can be a family member or friend. It cannot be a person involved in the design, conduct, or reporting of the research. So if you have a participant who cannot read, either because they are illiterate or they are visually impaired, you do need a witness, and it cannot be a member of the study team or anybody involved in the study. 5.1.5 says if the subject cannot speak English, obtain the services of an interpreter. So that interpreter can be a member of the research team. It can be a family member, it can be a friend. You just want them to be fluent in both English and the subject's language. And if you are using a short form for a non-English speaker in 5.2, it says that you want to obtain the current IRB approved short consent form and summary. And then retain documentation of the translation in your file. According to the SOP, the translation does not need to be submitted to the IRB. You can, but it's not required. But you do want the IRB approved short consent and summary form. You want to invite and answer questions. Give the subject time to discuss taking part in the research study with others. If they can take the written information home in advance, that's even better. And then 5.8 of the SOP says that if the subject has questions about treatments or compensation for injury, provide factual information and avoid statements that imply that compensation or treatment is never available. And this is where using that UB-IRB template language for research-related injury it's so important, because as long as that is accurate, you can refer back to that every time. Okay, 5.1.6 says, read the consent document with the subject. I don't interpret that as read the consent to the subject. I have seen that done. I don't have the patience for that, but you do want to read the consent document with the subject, explain the details in such a way that the subject understands what it would be like to take part in the research study. You can get creative. You can use PowerPoint. You can use additional reading materials, websites, simulations. You can refer someone to a previous subject if that previous subject has agreed. These all need to be IRB approved, but you can get creative. I worked on a study one time where we were asking people to have an EEG, and this was a population that had never had an EEG. They never would have an EEG. And we noticed when we were reviewing the consent form, people kind of got this like faraway look, and we realized like they don't know what we're talking about. We're describing it, but it's not making sense. So we started to pull out a cap. We'd say, this is what the cap is going to look like. We're going to put this on your head. Here's what the gel will look like. And we'd unscrew the gel and show it to them and say, this is like the syringe without the needle part. We're going to put all the gel in all these holes, and these are like the electrodes we're going to put on. And just showing them what we were going to use, people seemed to have a much better understanding, and they were able to ask questions about the gel and how tight will it be. And it was much easier to understand actually seeing what was going to be used instead of reading the description. So considerations for how. Am I following the regulatory requirements in HRP 090? And is there anything else that can be done to aid a participant in understanding the voluntary nature of their decision, the risks and benefits, and what it will be like to be part of the research? Can we reduce pressure to make a decision, whether that's due to time or other factors? And how will we determine whether or not a person is capable of consent? Should there be a formal process given the population? And we'll talk about that in a little bit. And is there anything that should be done differently to help ensure that a participant is able to freely make and communicate their decision to be part of the research? Okay. That was all about conveying information. That was only part one of that three-part process. Now on to understanding. So there is a difference between knowledge and understanding. And anybody that has ever spoken to a subject the night before a visit, and that subject has said, yep, I'll be fasting tomorrow. And then they show up at the clinic, like drinking an ice cap from Tim Hortons with like whipped cream on top. And you say, I thought you were going to fast. And they say, I am fasting. I didn't eat anything all morning. And you realize that your understanding of fasting is not the same as their understanding of fasting. And had you said, nothing to eat or drink except water after midnight, this whole situation could have been avoided. There is truly a difference between understanding and knowing something. So they knew they had to fast. Our understanding was different. So you really want to use those common everyday words, simple sentences, and target that 6th to 8th grade reading level. Learn from my mistakes. Don't tell somebody to fast. Tell them not to eat or drink anything except water. Now, what needs to be understood and when does it need to be understood? So not all information needs to be known throughout the entire study. After the decision is made, it's okay to forget some things. Now, you want everyone to always remember that it's voluntary, that they can withdraw at any time, but they don't necessarily need to remember every assessment at every visit. You want that information accessible. That's why you send home the consent form. But it's okay to remind them, and maybe you roll this into like a formal ongoing consent process. We always used to, like when somebody came in for a visit, we'd say, okay, today we'll draw blood, we're asking you questions, we'll do this procedure. Are you agreeable? And then when we scheduled the next appointment, we'd say, okay, so next time we're going to, do A, B, and C. Are you agreeable? And we documented those conversations in our source notes as a way to document that ongoing consent, that people know what's coming up, they know what to expect, and they continue to agree to participate. So how can we help to ensure understanding? So many of the things that we did in the process of conveying information were not as much about conveying the information, but to really help ensure understanding, providing the materials ahead of time, in the subject's preferred language if possible, inviting and answering questions, giving time to take information home and discuss it with others, providing that description of what it will be like to be part in a study. That is all in the effort of aiding understanding. And sometimes we have to tailor the conversation. So imagine you've got two subjects in 2 rooms for a type 2 diabetes studies. I should say 2 potential subjects. Say you've got John, he's 63. He was diagnosed in his 30s, but like lately he struggled to control his glucose levels. Then you have Mary, who's 25. She was recently diagnosed, and she's also planning on starting a family. So what do you think, or how do you think those conversations may vary? You're going to cover all the same topics but really ensure understanding. What topics might have, a different conversation around them for John versus Mary? What do you think?
Well, I was just going to say, in terms of relating information, I'm thinking that John is going to be a little bit more experienced with his own particular situation than Mary, just being recently diagnosed.
Yes, I totally agree. I think alternative treatment. So John probably doesn't need an in-depth discussion on alternative treatments. If he's been diagnosed for decades, he's probably aware of what his options are. But if Mary's recently diagnosed, she probably needs a longer discussion on what her options are. And again, somebody said pregnancy risk. There are birth control requirements, a risk to fetus or embryos, breastfeeding restrictions. Those things may be more important to Mary. And maybe they're important to John too, but it looks like, just based on this, that those might be more relevant to Mary in making this decision to participate or not. So the discussion might be a little different for her. Now, the methods of conveying information may also need to change over time. So children grow up and gain the ability to understand. So if you are assenting children and adolescents and they turn 18 during the course of the study, you will have them sign that adult consent form at that point. That's different than if you are maybe enrolling dementia patients who signed the consent form originally, but as time progressed and they had lessened cognitive ability, they may not be able to reconsent if that comes up. You may need to have an LAR or someone else as the study goes on. Now, 28.8 of the 503 does ask you to describe the process to determine whether an individual is capable of consent. And if you look at the SOP, 5.7 says, ask the subject questions to determine whether all of the following are true. And if not, either continue the explanation or determine the subject is incapable of consent. So you want to ensure that they understand the information provided, they don't feel pressured by time or other factors to make a decision, they understand that it's a voluntary choice, and that they are capable of making and communicating the informed choice. So we are not looking to quiz people, although I have seen quizzes. It's not something I recommend. I mean, you'd rather maybe just engage them in conversation, ask them to repeat back what you've talked about in their own words to see if they understand. Depending on your subject population, maybe you do need a more formal process, though, to determine like capacity to consent. Maybe you want to have a process where someone not involved in the study makes that determination. That's things to be thinking about based on your study and your population. Affirmative free choice. So back to the SOP, 1.2 says the process begins when an individual identifies a subject as a potential candidate. The process ends when the subject provides legally effective informed consent or declines to do so. Once the subject indicates they don't want to take part, the process stops. But lack of objection is not an indication of agreement. So when someone says, sure, whatever, I guess so, if you really want me to, that's not a yes. A yes is yes, I want to participate. And I've had subjects like, sure, okay, whatever. And we have made them say, yes, I want to, or no, I don't. And they didn't have to decide right then and there. They could keep thinking about it. But a sure, okay is not a yes, I want to participate. External influences should be minimized. Your own position as a healthcare provider can be an undue influence that is sometimes unavoidable. And signing the document is only an affirmation of choice. It is not the choice itself. So to recap, the informed consent process can be broken down into 3 parts: the conveying of information, the understanding of the information, and affirmation of free choice. And that is followed by documentation, whether that's the signing of the consent form, but also the documenting of the consent process in your source notes. And we always kind of had like a worksheet that we would capture all that information on, but you can capture it however you would like to. But documenting that process is important. So to also recap, the objectives was recognizing information in specific sections of the research protocol as corresponding to information being conveyed in the consent document, and also reviewing a guide for designing a consent process to improve informed consent in the future. And I think that will be sent out to you. So if anybody has any questions at any time, you can feel free to reach out to me at the CRO. And I think there was still one question in the chat that we were going to get to.
There is. Is it okay to obtain an online consent where the consent document, hold on a second, is sent to the potential participant via email in advance with information to ask questions if they do not understand the information in the consent?
Yeah, so you're going to submit your consenting process to the IRB, and they will determine if it is appropriate. But it is, in my experience, sending the information ahead of time has always been acceptable to the IRB. Of course, you want to tell people not to sign it, or that if they do sign it, they're going to sign a separate copy when you see them. Or depending on your electronic signing process, sometimes those are signed through RedCap. I know there's different processes for that. But as long as you have everything laid out in your protocol and the IRB approves it, then you can do that. I don't know if that answered the question, but I hope so.
So if no one has any questions, we can definitely sign off a little early, not a problem. That was incredibly informative. The engagement factors were great. And we really appreciate you taking this over. It was really, really well done.
Okay, yeah, well, thank you for everybody's time. And again, if you ever have any questions, please feel free to reach out.